Welcome to Chapter 11, the lungs, also known as the organs that absolutely refuse to take a day off. Every single cell in your body depends on these spongy little airbags doing their job correctly. And when they don't, pathology shows up fast and dramatically. From a histology perspective, the lung is one of the most elegant designs in the body. Extremely thin, extremely delicate, extremely unforgiving when damaged. It's basically the biological equivalent of tissue paper wrapped around capillaries. Throughout this lecture, we'll focus on lung structure and function, how disease disrupts gas exchange, what that disruption looks like under the microscope, and why your H&E slides often look either beautifully lace-like or completely terrifying. There's no pressure here. Here's what we're aiming to accomplish in this chapter. By the end, you should be able to understand normal lung anatomy and physiology, identify key lung cell types histologically, explain how smoking wrecks basically everything it touches, differentiate restrictive versus obstructive lung disease, interpret pulmonary function tests, recognize common lung diseases and infections, and understand lung cancers, especially their histologic classification. Think of this chapter as the bridge between microscope knowledge and real clinical pathology reports. This is one of those units where histology suddenly starts to make a lot of sense. Let's start with normal, because pathology is just normal gone wrong. At the functional level, the lung has one job: move oxygen in, move carbon dioxide out. That's it. Everything else exists to support that goal. Inside the alveoli, we find type 1 pneumocytes. They're thin, flat, squamous cells. They cover approximately 95% of the alveolar surface, and they are designed for gas exchange. Then there's type 2 pneumocytes. These are cuboidal, and they produce surfactant. These are the true heroes of lung stability, because surfactant reduces surface tension so the alveoli don't collapse like sad little wet balloons. Between the alveolus and the capillary sits the alveolar capillary membrane, made of type 1 pneumocytes, basement membrane, and capillary endothelium. In some areas, that barrier is less than 0.5 micrometers thick. That's thinner than most excuses students have for late assignments. Fun fact, if you unfolded all the alveoli in adult lungs, the total surface area would be roughly the size of a tennis court, which explains why even mild inflammation can cause major problems. Cigarette smoke is not subtle. It doesn't gently irritate the lung. It shows up like a wrecking ball. Histologically and physiologically, smoking increases mucus production, it paralyzes cilia, promotes chronic inflammation, it disrupts enzyme balance, and it destroys alveolar walls. Now let's talk cilia for a moment. Cilia normally act like tiny synchronized custodians, sweeping mucus upward towards the throat. Smoking paralyzes them, kills them, and then increases mucus production anyway. So now you have more mucus and less movement. This is why smokers develop chronic cough. The lung is literally trying to manually remove debris that the cilia can no longer clear. From a slide perspective, you'll often see goblet cell hyperplasia, thickened bronchial walls, and chronic inflammatory infiltrates, eventually contributing to COPD, cardiovascular disease, stroke, diabetes, and cancer. So yes, smoking truly is an equal opportunity destroyer. This is one of the most important conceptual slides in this entire chapter. Here's the easiest way to remember it. Restrictive means can't get air in. The lungs are stiff. Examples include interstitial lung disease, sarcoidosis, obesity, and pulmonary fibrosis. Problem isn't airflow, it's expansion. Histologically, you'll often see thickened alveolar septa, fibrosis, and reduced alveolar compliance. Obstructive means you can't get air out. The airways are narrowed or blocked. Examples of this include asthma, COPD, chronic bronchitis, emphysema, and cystic fibrosis. Histology shows mucus plugging, smooth muscle hypertrophy, and loss of alveolar walls, especially in emphysema. If restrictive lungs are stiff balloons, obstructive lungs are balloons with clogged straws. Both bad, just different mechanisms. Spirometry gives us objective data on lung performance. So key terms here, we have FEV1. This is how much air you can blow out in 1 second. And then we have FVC, which is the total volume exhaled after maximal inhalation. In obstructive disease, FEV1 drops dramatically. FVC may be normal or slightly reduced. The FEV1 over FVC ratio decreases. In restrictive disease, both FEV1 and FVC decrease. Ratio often remains normal. This is why spirometry is so powerful. It tells clinicians where the problem is happening. Histology helps explain why. When alveolar walls are destroyed, airflow dynamics change. When fibrosis thickens septa, volume drops. Microscope meets physiology. Bronchoscopy is essentially a guided tour of the airways with sampling. Through a bronchoscope, clinicians can collect bronchial washings, bronchoalveolar lavage, also referred to as BAL, brushings for cytology, and tissue biopsies. This is where histotechnologists enter the story. Those tiny fragments you embed may determine infection versus malignancy, the tumor type, and treatment decisions. And yes, lung biopsies are small, fragile, and love to fold, so handle gently. They are emotionally delicate specimens. Some worthless knowledge? The bronchoscope was first developed in the late 1800s, initially to remove foreign bodies from airways. Early versions had light bulbs inside them, because nothing says medical innovation like electricity in a moist airway. Atelectasis means alveolar collapse. It does not mean the lung is gone, it means it's not expanded. Causes include external compression, pleural effusion, normal pneumothorax, mucus plugs, tumors, and foreign bodies. Histologically, collapsed lung appears dense, airless, and hypercellular. The alveoli are present, just deflated. Clinically, patients present with wheezing, cough, dyspnea, and treatment depends entirely on the cause. Remove the blockage, relieve the pressure, reinflate the lung. Think of it like a stuck air mattress valve. Pulmonary edema occurs when fluid fills the alveoli. Instead of air, you now have pink, protein-rich fluid where oxygen should be. Causes include increased pulmonary venous pressure, hello heart failure, infection, trauma, and drug reactions. Histologically, you'll see alveoli filled with eosinophilic fluid, engorged capillaries, and possibly some hemosiderin-laden macrophages, also known as heart failure cells. These are macrophages that have eaten leaked red blood cells. Clinically, pulmonary edema causes severe shortness of breath, wheezing, cyanosis, and orthopnea. This is one of the most dramatic examples of how even tiny changes in alveolar environment can severely impair gas exchange. Remember, the lung tolerates air and surfactant. Anything else is a problem. All right, this is one of the big ones. COPD is not a single disease. It is a chronic, progressive, airflow limitation syndrome caused by persistent inflammation and structural remodeling of the airways and alveoli. About 80% of cases are linked to cigarette smoking, but occupational exposure and air pollution also play roles. So what's actually happening in COPD? Well, COPD combines two overlapping disease processes: chronic bronchitis, which is an airway problem, and emphysema, which is an alveolar problem. Most patients have features of both. Histologically, COPD shows chronic inflammation, so we'd see neutrophils, macrophages, lymphocytes. We'd see increased mucus secreting cells, thickened bronchial walls, smooth muscle hyperplasia, destruction of alveolar septa, and loss of pulmonary capillary beds. In simple terms, the lungs become inflamed, narrowed, clogged, and floppy all at once. And why airflow obstruction occurs is that normally during expiration, elastic recoil of alveoli pushes air out. In COPD, the alveolar walls are destroyed. The elastic recoil is lost, so airways collapse prematurely and air gets trapped. That's why these patients can inhale but can't exhale effectively. And as histotechnologists, when you see enlarged air spaces, thin or missing septa, inflammatory infiltrates, and excess mucus, you should immediately think this lung cannot move air properly. Some worthless knowledge here is COPD used to be nicknamed the smoker's lung disease, but we now know up to 25% of patients have never smoked. Many are exposed through occupation, secondhand smoke, or biomass fuels. Chronic bronchitis is the airway dominant form of COPD. The diagnostic criteria is very specific: productive cough for at least 3 months in at least 2 consecutive years. If that timeline isn't met, it's not chronic bronchitis yet. So the etiology is cigarette smoke, which is primary, air pollution, occupational irritants, and chronic infection. Some histological features: under the microscope, you'll see marked goblet cell hyperplasia, enlarged submucosal glands, chronic inflammatory infiltrates, thickened bronchial walls, and narrowed airway lumen. The classic measurement is the Reid index. So a normal measurement on the Reid index is below less than 40%, and for chronic bronchitis, you have to have above 50%. This reflects excess mucus producing glands relative to the thickness of the bronchial wall. So more glands equals more mucus equals more obstruction. Patients with chronic bronchitis experience persistent productive cough, thick sputum, frequent respiratory infections, and hypoxia. Historically described as blue bloaters due to cyanosis and fluid retention. Yes, it's outdated terminology, but you may still see it written in the older literature. As a histology takeaway, in chronic bronchitis, the problem is the airway. Alveoli may initially be preserved. Oxygen can't reach them because mucus blocks the path. Think too much junk in the tubes. Emphysema is the alveolar dominant form of COPD. It is defined as permanent enlargement of air spaces distal to the terminal bronchioles, with destruction of alveolar walls and no obvious fibrosis. Key word here is permanent. Once alveoli are destroyed, they do not regenerate. Some etiology includes the most common, which is cigarette smoke, air pollutants, alpha-1 antitrypsin deficiency. So alpha-1 antitrypsin normally protects lung tissue from neutrophil elactase. Without it, elactase destroys alveolar walls unchecked. The result is early onset emphysema, often before the age of 40. Histologic features: on H&E, we'll see markedly enlarged alveolar spaces, thinning or absence of alveolar septa, decreased capillary network, and reduced surface area for gas exchange. The lung begins to resemble bubble wrap that has been popped. Some functional consequences are decreased elastic recoil, air trapping, some hyperinflation, flattened diaphragm, and increased work of breathing. Patients often present with severe dyspnea, weight loss, barrel chest, and prolonged expiration. Historically called pink puffers, again, outdated language, but useful for conceptual learning. Key histology comparison. So if you see thick bronchial walls and mucus, think bronchitis. Enlarged alveoli and missing septa, think emphysema. Both together are components of COPD. But a big takeaway for you students is COPD is devastating, not because of inflammation alone, but because structural lung architecture is permanently altered. Histology explains the symptoms. When the structure changes, the physiology follows. All right, now let's talk about asthma, which is one of the most common obstructive lung diseases you'll see both clinically and histologically. Asthma is fundamentally a disease of hyperreactive airways. Think of these bronchi as being emotionally unstable. They overreact to things that couldn't be that big of a deal. Pollen, or that shouldn't be that big of a deal. So pollen, dust, cold air, stress, exercise, and viral infections. Basically, the lung version of I'm fine, actually, no, I'm not. In asthma, the problem is not the alveoli. The problem is the airway wall. Key histologic features include bronchial smooth muscle hypertrophy and hyperplasia, edematous mucosa, goblet cell hyperplasia, thickened basement membranes, and increased eosinophils and mast cells. If you see eosinophils hanging out in the airway wall like they own the place, asthma should immediately pop into your head. But what's actually happening? Well, during an asthma attack, the smooth muscle contracts, the mucosa becomes inflamed, mucus production skyrockets, and the airway lumen becomes dramatically narrowed. So even though air can get in, it has a really hard time getting back out. That's why asthma is classified as an obstructive disease. This leads to wheezing, cough, chest tightness, hypoxia during severe attacks. And importantly, asthma is usually reversible, either spontaneously or with bronchodilators. That reversibility is a huge diagnostic clue. Some worthless but fun knowledge: the thickened basement membrane seen in asthma is due to collagen deposition beneath the epithelium, not true basement membrane thickening. Pathologists noticed it looked thicker and the names stuck. Histology does lie sometimes. Now we shift gears into something much more serious: ARDS, ARDS, or acute respiratory distress syndrome. If asthma is airway chaos, ARDS is alveolar catastrophe. This is not a slow, chronic process. This is sudden, severe, and often life-threatening. What triggers ARDS? Well, ARDS is not a primary lung disease. It's a reaction to massive systemic injury. Common triggers include severe infection or sepsis, trauma, inhalation injury, pancreatitis, uremia, or massive immune activation. Basically, when the body is in full inflammatory meltdown mode. The injury targets the alveolar capillary membrane. What should be thin and delicate suddenly becomes inflamed, leaky, and flooded. Histologically, we see diffuse alveolar damage, protein-rich edema, hyaline membrane formation, collapsed alveoli, and loss of surfactant. Those pink hyaline membranes you see lining alveoli, well, that's plasma proteins and dead epithelial cells forming a barrier to gas exchange. Oxygen hits that wall and says, absolutely not. Even though the lungs may look full, they are essentially stiff, non-compliant, and unable to exchange gases. This leads to severe hypoxemia, tachypnea, cyanosis, and respiratory failure, and often the need for mechanical ventilation. A fun fact that actually isn't too much fun is that ARDS was originally called shock lung, which honestly was a very accurate name. Now let's move into restrictive lung disease family, specifically chronic diffuse interstitial lung diseases, or ILDs. These diseases don't primarily affect airways. They affect the interstitium, the connective tissue scaffold that lives between alveoli and capillaries. The interstitium is normally thin, flexible, barely noticeable, and perfect for gas diffusion. In ILDs, that interstitium becomes inflamed, thickened, fibrotic, and scarred, which drastically increases diffusion distance for oxygen. Gas exchange normally happens across tissue as thin as plastic wrap. Interstitial lung disease turns that plastic wrap into a winter coat. Oxygen now has to work too hard to cross. Histologic features include interstitial fibrosis, increased fibroblasts, thickened alveolar septa, loss of normal alveolar architecture, and reduced capillary proximity. Over time, alveoli become stiff and collapse prone. This results in decreased lung compliance, reduced lung volumes, and increased work of breathing. Patients can inhale air, but the lungs simply won't expand. That's why ILDs are restrictive diseases. Patients present with progressive dyspnea, tachypnea, fine inspiratory crackles, or what also referred to as Velcro crackles, and cyanosis in advanced disease. And unfortunately, many forms are irreversible. Some worthless knowledge here is that smoking is one of the strongest risk factors for interstitial lung disease, even in cases where the exact cause is technically unknown. The lungs remember everything. All right, histology friends, this slide introduces pneumoconiosis, which is essentially the lung remembers everywhere you've ever worked. Pneumoconiosis refers to a heightened inflammatory reaction to inhaled inorganic dusts, most commonly encountered in occupational settings. These aren't your everyday allergens. We're talking tiny particles that make it all the way down to the alveoli and refuse to leave. Once these particles are inhaled, the alveolar macrophages attempt phagocytosis, and spoiler alert here, they fail. The macrophages then release inflammatory mediators, fibroblasts get recruited, and collagen deposition follows. And just like that, we have interstitial fibrosis. Think of it like glitter. You didn't invite it, you can't get rid of it, and it will haunt you forever. Some major types you should recognize is we have silicosis. This is caused by the crystalline silica exposure, so mining, sandblasting, stone cutting. Histology shows dense, whorled collagen nodules, often birefringent under polarized light. This doubles the risk of lung cancer, so just a little important pearl there. Then we have asbestosis from inhalation of asbestos fibers. A histological hallmark is that we have asbestos bodies, or also referred to as ferruginous bodies. They're golden brown rods with iron coating, strongly associated with mesothelioma, which is a lung carcinoma, especially, you know, and then there'd also be lung carcinoma, especially with smoking. So we have anthracosis, which is carbon accumulation in lungs and lymph nodes. It's very common in urban dwellers, in smokers, and especially coal mine workers. Often asymptomatic, but visually dramatic. These blackened lymph nodes, they are completely real and oddly impressive. So worthless knowledge are coal miners. Pneumoconiosis is sometimes called black lung disease, which sounds metal, but is unfortunately not. This one is fun because the name sounds terrifying, and the pathology kind of is. Hypersensitivity pneumonitis is an immune-mediated interstitial lung disease caused by repeated inhalation of organic antigens, not toxins, not smoke, not dust, but things like mold spores, bacteria, bird proteins, animal droppings, and contaminated humidifiers and air conditioners. Basically, your hobbies are attacking your lungs. Some classic examples are farmer's lung. So this can result from moldy hay. We have bird fancier's lung, which are proteins in bird feathers and droppings. Air conditioner lung, which is contaminated ventilation systems. So what's happening histologically? Well, repeated exposure leads to type 3 and type 4 hypersensitivity reactions. We'd see interstitial lymphocytic inflammation, formation of poorly formed non-caseating granulomas, and eventually that leads to chronic interstitial fibrosis. This is not infection. No organisms are invading tissue. This is simply your immune system being deeply dramatic. Some clinical manifestations would be fever, cough, dyspnea. Symptoms worsen over exposure and improve when away. Students often remember this one best when they hear patients feel fine on vacation, sick again when they go back to the barn. Some treatment is remove the antigen, corticosteroids if inflammation persists. Histology takeaway is you think patchy interstitial inflammation and small granulomas. Not as well formed as sarcoidosis. Distribution tends to center around the bronchioles. And now we arrive at one of pathology's favorite mystery guests, sarcoidosis, which is a systemic granulomatous disease of unknown etiology. And yes, you will see this many times over. About 90% of cases involve the lungs, even though sarcoidosis can affect nearly any organ system. So the suspected mechanism is we have a dysregulated immune response, and that causes an increased CD4 positive T cell activity, which then is elevated cytokine production. And then we have formation of non-caseating granulomas. Important word here to remember is non-caseating. So no cheese, no necrosis, no TB. Okay? Histology highlight is we will see tight, well-formed granulomas that are composed of epithelioid macrophages and multinucleated giant cells. These are often found along lymphatics, bronchovascular bundles, and you may also see Schwann bodies or also laminated calcium inclusions. That's what they're called. Asteroid bodies, which are star-shaped cytoplasmic inclusions. These are not required for diagnosis, but very satisfying to spot under the microscope. Some clinical manifestations is shortness of breath, dry cough, chest pain, bilateral hilar lymphoidopathy on imaging is classic. Sarcoidosis is often diagnosed by ruling out everything else first. It is the ultimate diagnosis of exclusion. Some treatments would be corticosteroids, and some cases resolve spontaneously. Others will progress to pulmonary fibrosis. By the end of these slides, you should understand that interstitial lung disease equals thickened alveolar walls. So the gas exchange becomes impaired, not because air can't enter, but because oxygen can't cross the barrier. Fibrosis equals permanent architecture damage. These are diseases you recognize histologically, not clinically alone. Or as I like to summarize it, the alveoli are open, but the walls are too thick to do their job. This is one of those slides where pathology finally looks exactly like pathology. Pneumonia is essentially the lungs version of the party got way out of hand. Normally, alveoli are beautiful, open, delicate air sacs. Think tiny soap bubbles designed purely for gas exchange. In pneumonia, those air spaces become filled with inflammatory exudate instead of air. Histologically, this is key. Instead of nice open white spaces, you'll see alveoli packed with neutrophils, fibrin, protein-rich fluid, and sloughed pneumocytes. In other words, air is replaced by gunk. That's why patients feel like they're drowning on dry land. Some histology clues you should recognize are the alveolar spaces filled with pink fibrin, tons of neutrophils, thickened alveolar septa, and loss of visible air spaces. If you're scanning a slide and thinking, why is every alveolus full of purple dots? Congratulations, you're probably looking at pneumonia. So some etiology that matters clinically, but histology overlaps, is bacteria pneumonia. So we'd see neutrophil heavy exudate. Viral pneumonia, it's more interstitial inflammation. Fungal pneumonia, you'd see granulomas or organisms. So here PAS or GMS would be your best friend. Mycoplasma, so more subtle, often interstitial. We'd have some worthless knowledge here. We have lobar pneumonia, so the whole lobe is involved. Then you have bronchial pneumonia, so you'd have patchy airway-centered involvement. Same disease process, just different distribution pattern. Okay? So bottom line for histotext is this. If the alveoli are full instead of empty, oxygen can't get in. No oxygen equals dyspnea, fever, productive cough, and very unhappy patients. Now we enter the land of granulomas, one of pathology's favorite hobbies. Tuberculosis is caused by the Mycobacterium tuberculosis, which is acid-fast, slow-growing, and extremely patient, like months to years patient. Some histology hallmarks are caseating granulomas. That word matters. So granuloma is organized immune response, and caseating means that it has a necrotic center that looks like crumbly cheese. On H&E, you'll see central pink acellular necrosis surrounding epithelioid macrophages, and we'd see Langerhans giant cells. So these are nuclei in a horseshoe pattern. We'd also see peripheral lymphocytes. If you stain it with Ziehl-Neelsen, the bacteria show up bright red because they absolutely refuse to decolorize. TB likes the apical lung regions because higher oxygen tension. Microbacteria are aerobic. So when you hear apical cavitary lesions on X-ray, that should immediately scream TB. And then we have latent versus active TB. Well, latent TB, granulomas wall it off and patient is asymptomatic. Active TB means there's a breakdown of the granulomas, the organisms spread, and then tissue destruction occurs. That breakdown is what causes weight loss, night sweats, cachexia, hence the old term consumption. Some worthless but memorable knowledge. TB granulomas can calcify and become GON complexes, GHON, which are basically the lungs saying, I survived something terrible and kept the receipt. This slide is less about airways and more about plumbing. Pulmonary embolism is not a lung problem first. It's a vascular problem that becomes a lung problem very quickly. Over 95% of emboli come from deep veins in the legs. They travel from the leg to the IVC, to the right heart, to the pulmonary artery, and uh-oh. But what happens next? Well, the embolus then blocks blood flow. So even though air is present in the alveoli, there's no blood to pick up the oxygen. This creates ventilation without perfusion, which is completely useless. In pulmonary infarction, we may see wedge-shaped hemorrhagic infarcts, coagulative necrosis of lung tissue, alveoli filled with red blood cells, and damaged capillaries leaking blood. Why hemorrhagic? Well, because lungs have dual blood supply, pulmonary and bronchial circulation, so blood leaks into the dying tissue. Infarction usually occurs 3 to 7 days after embolism, not immediately. So if you're looking at necrotic lung tissue days later, think infarct, not embolus. We might have there's small PEs or pulmonary emboli, which are shortness of breath, chest pain, and tachypnea. And then we have large PEs, which are sudden collapse or death. This is why PEs are often called the great masqueraders. Patients can have completely normal lungs histologically if death occurs rapidly because there's not enough time for infarction to develop. Pathology sometimes tells the story, and sometimes the story ended too fast. So by the time we finish this slide, you should be able to understand that pneumonia are alveoli filled with inflammatory exudate, TB, granulomatous inflammation with casus necrosis, PE/infarction, vascular obstruction leading to ischemic lung injury. 3 very different diseases, 3 very different histologic patterns, all ending with the same clinical complaint: I can't breathe. Okay. Now we're moving into pulmonary hypertension, which sounds deceptively simple, but is actually one of those quietly destructive lung conditions. Pulmonary hypertension means exactly what it says: increased pressure in the pulmonary arteries. Not systemic blood pressure, not my doctor said my BP is high. This is high pressure specifically in the vessels feeding the lungs, and that difference matters a lot. Normally, pulmonary arteries are thin-walled, low pressure, very chill vessels, and they're not built for resistance. But when chronic lung disease or vascular injury occurs, we see medial hypertrophy, which is smooth muscle thickening. We see intimal hyperplasia and progressive luminal narrowing. On histology, that artery starts to look more like, why do you suddenly resemble the aorta? Spoiler, the lung does not appreciate this. Why this becomes a heart problem? Well, as pulmonary artery pressure increases, the right ventricle has to work harder to push blood forward. Over time, this causes right ventricular hypertrophy, eventual right-sided heart failure, and this is called cor pulmonale. And yes, I know we've heard that term already come up several times. Imagine trying to blow air through a wide drinking straw. Pretty easy, right? Try blowing air through one of those tiny coffee stirrers. It's pretty exhausting. That's what the right ventricle is dealing with. If you're looking at pulmonary vessels on a slide, thick and smooth muscle is a red flag. Narrowed lumen equals resistance, and small arteries that look way too muscular means pulmonary hypertension. And remember, this is often secondary, not primary. Some worthless but fun knowledge: pulmonary hypertension used to be nicknamed the disease of the disappearing vessels because capillary beds are gradually lost as pressure rises. Let's take a collective deep breath because lung cancer is heavy, but it's also extremely high yield. Lung cancer remains the leading cause of cancer death in the US, not because it's the most aggressive, but because it's often diagnosed late. From a histology standpoint, this is where your epithelial knowledge really pays off. About 95% of lung cancers originate from airway epithelium, meaning bronchiolar, alveolar lining cells. So if you know epithelial changes, you're already ahead. Some major categories are non-small cell lung cancer, or NSCLC, and this is about 85%, and that includes adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. Adenocarcinoma is the most common type overall, often occurs in non-smokers and former smokers. It arises peripherally. It's gland forming or mucin producing. And some histology features we'd see are granular structures, mucin positivity, so PAS and Austrian blue cameo stain. These are often easier to surgically resect because they're not hugging major bronchi. And then we have squamous cell carcinoma, which is strongly associated with smoking. It arises in the main bronchi and is often centrally located. Histology would show keratin pearls and intracellular bridges. If you see pink whorls screaming for attention, That's your squamous friend. And then we also have small cell lung cancer, so SCLC. This one deserves respect. It's highly aggressive, it has rapid growth and early metastasis, and it's of a neuroendocrine origin. So histology wise, we would see small blue cells, scant cytoplasm, nuclear molding, and high mitotic rate. This is the one that makes pathologists sigh quietly. Small cell carcinoma responds well to chemo initially, then almost always comes back angry. Different tumors respond to different chemotherapy agents, targeted therapy, and immunotherapy. So yes, what you see on the slide directly influences patient treatment. Absolutely no pressure though. Now let's connect what we see microscopically with what this looks like grossly and clinically. On gross examination, lung carcinomas often appear as firm gray-white masses with irregular borders, areas of necrosis, and obstruction of bronchi. That obstruction explains a lot of symptoms. So obstruction typically leads to atelectasis distal to tumor, recurrent pneumonia, and persistent cough, which is why many patients present with, "I've had pneumonia 3 times in the same spot." Pathologists immediately raise an eyebrow. Some histologic effects: tumors may invade bronchial walls, destroy alveolar architecture, cause hemorrhage, and induce fibrosis. And depending on location, so central tumors may lead to hemoptysis, and peripheral tumors would cause pleural pain and effusion. Sorry about that. Clinical manifestations make sense when you see the slide. So there'd be dyspnea, loss of functioning lung tissue. There'd be weight loss, so cancer metabolism and cytokines. Hemoptysis, which is friable tumor invading vessels. Histology explains symptoms beautifully once you know what to look for. Treatment depends on tumor type, the stage, and the molecular markers. And options include surgical resection, chemotherapy, target therapy, radiation, and increasingly immunotherapy. Some worthless but fascinating knowledge is that some lung adenocarcinomas express TTF1, which helps distinguish primary lung cancer from metastatic tumors from elsewhere. Immunohistochemistry saves lives and our sanity. Okay, this slide looks intimidating at first glance, but I promise it's actually very logical once we slow it down. This is the TNM staging system, which is the standardized way cancers are staged worldwide. Not just lung cancer, but many solid tumors. TNM answers 3 very simple questions. How big is it? Where has it gone? And how far has it spread? Let's break that down. T equals tumor. The T category describes the size of the primary tumor and how far it has grown into nearby structures. In lung cancer, this includes the actual diameter of the tumor and whether it has invaded the bronchi, pleura, the chest wall, or nearby lung tissue. So think of T as the real estate question. How much lung is this tumor taking up, and is it staying in its lane? A small localized tumor gets a lower T number. A large tumor invading surrounding structures gets a higher T number. And then we have N for nodes. The N category focuses on lymph node involvement. This is critical in lung cancer because the lungs are packed with peribronchial lymph nodes, hilar lymph nodes, and mediastinal lymph nodes. Once tumor cells enter lymphatic channels, the disease becomes much harder to control. So N staging tells us, has the cancer spread to lymph nodes? And if so, which ones? Nodes closer to the lung carry a better prognosis than nodes deeper in the mediastinum or on the opposite side of the chest. And then M stands for metastasis. And finally, the one everyone remembers is metastasis. This answers the question, has the cancer left the lung entirely? Common metastatic sites for lung cancer include the brain, bone, liver, adrenal glands, and the opposite lung. Once distant metastasis is present, the disease is automatically considered advanced, regardless of the tumor size. When we combine T, N, and M, we get overall stage groupings. So stage 1 is small tumor confined to the lung, no lymph node involvement. Stage 2 is a larger tumor, possibly nearby lymph nodes are involved. Stage 3 is significant lymph node involvement, and we have local extension. And then stage 4, we would see distant metastasis and disease has spread beyond the chest. You can see that progression illustrated in the images on this slide, from a small isolated lung tumor to widespread metastatic disease. Now here's why this connects directly to your role in the lab. Staging depends on tumor measurements, margin assessment, lymph node sampling, and accurate identification of metastasis. That means every lymph node you submit matters. Orientation affects staging. Missed nodes can alter treatment decisions. Two patients can have tumors that look similar under the microscope, but their stage may be completely different depending on where tumor cells are found. Microscopically, staging correlates with depth of invasion, vascular and lymphatic invasion, tumor emboli in lymphatics, and metastatic deposits in nodes. So while staging is ultimately a clinical designation, it is built on histologic evidence. Pathology doesn't just diagnose cancer, it defines how advanced it truly is. Quick analogy here is think of T and M like wildfire tracking. T is how big the fire is, N is whether nearby areas are burning, and M is whether embers have jumped miles away. A small contained fire is manageable. A wildfire with spot fires everywhere is a very different situation. Bottom line here is that T and M staging can guide prognosis, determine treatment options, and predict survival. And it also relies heavily on accurate pathology evaluation. Now, you don't need to memorize every number on this slide. What you do need to understand is cancer staging is about location, spread, and tissue involvement, not just tumor type. And that's why histology matters so much in the process. All right, that brings us to the end of our lung chapter. We covered a lot of material, including normal lung structure and function, infectious processes like pneumonia and tuberculosis, vascular conditions, and major lung carcinomas. So if your brain feels a little full right now, that's completely normal. The lung is one of those organs where structure, function, and pathology are tightly connected. And once those pieces click together, everything starts to make more sense. Remember, you're not expected to memorize every disease name. What I want you to focus on is where the damage occurs, what the tissue looks like histologically, how that structural change explains the patient's symptoms. That skill, linking morphology to function, is what makes you a strong histotechnologist. If you have any questions at all, reach out by email, ask during office hours, or send me a message through Canvas. Remember that all images in this lecture are for educational purposes only and are meant to help train you. I know that sounds redundant, but they ask that we repeat that and make that known. You are learning to recognize patterns, not diagnose patients. That comes later after the microscope if you decide to go on or whatever. So take a breath, literally and figuratively, and when you're ready, you can move on to the chapter 12, which is the last one of this module. You've got this.